Hello and welcome. I'm thrilled to see you here for the second of the Applied Social Science Group annual symposium lectures. We heard yesterday from Greg Miller, and today we're going to be hearing from Edith Chen, and the topic for today is resilience, maintaining good health in the face of adversity. And as I mentioned last time, we're grateful to people who've come to film the lecture, which will be a teaching resource for the medical students who have Greg and Edith's work as core syllabus for them. So the chance to be able to see them in Cambridge, I think, will be quite special. In terms of thank yous, again, I want to thank our sponsor, the Wellcome Trust. I want to offer really a very great thank you to Guy Skinner, who's done fabulous work helping put this together. And yeah, here, absolutely. And also to Professor Jonathan Mant for chairing yesterday so beautifully, and also for offering to chair today. Just ahead of the beginning of the talk, I won't hold you for long, but so just mention a few things that are coming up. One is that Marion Backermans-Cronenberg, who you heard speak yesterday, will be delivering the Bradford Hill Seminar on Friday the 18th of May, 1 till 2 p.m, and that'll be in the Institute of Public Health. And she'll be talking on the power of parenting support. And if you've been interested in the themes of yesterday's lecture and today's lecture, I think this will be right up your street. And additionally, I also want to advertise an upcoming conference which will be hosted at St John's College, hosted by the St John's College Reading Group on Health Inequalities. The topic of the conference will be on comparative perspectives on social inequality in life and death, an interdisciplinary conference. And at the end of the conference, a separate event is going to be a public lecture from 5 till 6:15 in honour of Robert Hind, who was the former master of St John's. And that lecture is going to be on development of social behaviour in children from infancy, neurobiological, relational and situational interactions. One of the presenters of that lecture is going to be one of the discussants today, Marina Sven Eichendorn. So thank you very much. Over to Jonathan.
Thanks, Robbie. Welcome to day two. So as Robbie just put it to me yesterday, we were delighted to hear Greg present all the problems, and we're looking forward to Edith Chen this evening to present all the solutions. So no hard task there then. But by way of formal introduction, Edith Chen is co-director of the Foundations of Health Research Centre and Professor of Psychology at Northwestern University, and a faculty fellow at the Institute for Policy Research there. And her research focuses on understanding the psychosocial and psychobiological pathways that explain relationships between low socioeconomic status and physical health outcomes in childhood. And her topic today is resilience, maintaining good health in the face of adversity. Edith, welcome.
Okay, good evening, everyone. Can everyone hear me okay? Okay, great. I have a lapel mic today, so I've been told I don't actually have to stand behind the lectern the whole time. So thank you very much to Robbie and to Guy for organizing this wonderful symposium and for inviting us to be a part of it. It's been a very special time for us. And I want to thank as well the fantastic discussants and moderator that we have who have so generously taken time out of your busy schedules to come and share your thoughts and comments today. So it's been great having a chance to meet and interact with all of you. So my talk today is going to continue the conversation around health disparities, that is differences in physical health outcomes by socioeconomic status. And as everyone here is likely well aware after Greg's talk yesterday evening, there are strong socioeconomic gradients when it comes to physical health outcomes. So if we think about your family's level of income as a function of federal poverty levels in the United States, which for a family of 4 in 2018 would be around $25,000 US dollars. The closer one is to poverty levels, the higher your risk for a variety of poor outcomes in adulthood, including heart disease, stroke, and diabetes. And the relationship is fairly linear, as Greg pointed out yesterday. Now, this is true in adult health outcomes. We also know that poverty is a very significant issue in childhood as well. In the United States, we have about 1/4 of our children living under poverty levels currently. And when we look at health outcomes that are relevant to children, we find a very similar kind of gradient effect. So that is, the closer a family is to poverty levels, the greater the risk the child has for asthma or obesity, as just two examples of outcomes. So the talk yesterday that Greg gave focused on understanding some of the biological pathways behind these effects. So how we get from this broad epidemiological relationship of socioeconomic status and physical health through kind of understanding the effects on how it gets under the skin, in a sense. And the talk today is going to focus on health-related resilience. And by this, what I mean for the purposes of the talk is the idea of youth who manage to show good physical health profiles despite coming from growing up under adversity. So in this case, meaning growing up under low socioeconomic status or under conditions of poverty. Greg's talk yesterday was much more of a broad overview of the health disparities literature, and my talk today is going to be much more specific about the types of studies that we've done in our research center. And I imagine that most of you probably came to the talk last night, but in case there are some of you who weren't able to make it last night, I'm going to do just a mini overview about the sort of biological mechanisms that we focus on, just to make sure that everyone is on the same page before I start getting into studies and the results of studies that we've done on health-related resilience. So as Greg discussed yesterday in great depth, one of the key biological mechanisms that we've been interested in our lab is the role of inflammation. So as all of you likely are well aware, the immune system is one of the key frontline defenses that your body has against external threats. So things such as pathogens or things like getting wounded. And when certain cells in your immune system register the presence of some kind of threat stimulus like a virus or a bacteria, these cells can secrete molecules known as cytokines, and these cytokines orchestrate a variety of inflammatory events. So they can, for example, signal certain immune cells to go to the site of infection or injury. They can signal other cells to proliferate or divide. They can signal other cells to engage in killing mechanisms. And as Greg mentioned yesterday, these kinds of responses are critical for the survival of us as an organism. But it also is a response that has to be carefully regulated. And what we and others have hypothesized is that chronic stressors such as poverty can essentially engender what we call a pro-inflammatory phenotype. And that phenotype is characterized by two components. So the first is this idea of having excessive inflammatory responses to microbial challenges. So that is when your immune cells detect the presence of virus or bacteria, that they are mounting a more aggressive or heightened inflammatory response to that challenge. And the idea is that if you have that kind of excessive cytokine response over time, if you maintain those high levels of cytokine, that can lead to that sort of chronic, those chronic levels of low-grade inflammation that Greg talked about yesterday that are risk factors for a number of chronic diseases of aging, like heart disease and stroke. So the first idea is this idea of having an inflammatory response that's too ramped up or too turned on. That's one way that you can get to chronic levels of inflammation. But a second aspect of the inflammatory response is that while it needs to get turned on, it also needs to get shut down when it's no longer needed. And so a second way that you can get to chronically elevated levels of inflammation is by having immune cells that are insensitive to inhibitory hormonal signals. That is, when it's time for inflammatory responses to be terminated, hormones such as cortisol are secreted, and they signal immune cells to essentially shut down or dampen their inflammatory responses. So another way that you can get to excessive cytokine production, essentially, is if you have immune cells that become insensitive to signals from cortisol. So they stop responding to cortisol, and then as a result, you don't get inflammatory responses that shut down, and you have these elevated levels of essentially chronic inflammation. So we're interested in both these processes, the extent to which immune cells under certain conditions, perhaps related to poverty, might be turned on or ramped up, and as well the idea that immune cells that aren't shutting down when they're supposed to. Okay, so we look at both of these kind of biological mechanisms in studies of resilience that we do. Now, how do we do that? Greg discussed this some yesterday, but just to kind of recap, the way that we do this is we do this by what we call in vitro testing. So we could bring you into our research center, we draw blood on you, and then we expose your immune cells to a substance such as LPS, or lipopolysaccharide. This is a portion of bacteria's cell wall, and what happens is that when your immune cells detect the presence of LPS, they start secreting these pro-inflammatory cytokines like tumor necrosis factor alpha, interleukin-6, interleukin-1 beta. So what we're doing here is we're asking the question of, if we take blood from each one of you in this room and we expose each of your immune cells to an identical dose of LPS, are some people's immune cells going to mount a more aggressive or heightened inflammatory response, producing more of these pro-inflammatory cytokines than other people's immune cells? And that's an indication that those people's immune cells might be too turned on or ramped up, their inflammatory response. So we can look at this kind of paradigm in healthy participants, which is what we do in this kind of paradigm. We can also, as Greg mentioned yesterday, look at how these processes work in samples that have a chronic illness and illnesses that revolve around inflammation, such as asthma, which is the most common chronic illness in childhood. So when we do this kind of testing in the context of asthma, we do a very similar paradigm, but just with a different kind of substance. So we expose immune cells, draw blood on you, expose your immune cells, in this case, instead of LPS, to a substance called PMA-ionomycin. This substance induces certain kinds of immune cells called T helper cells to produce cytokines. And it's a certain class of T helper cells called Th2 cells that are implicated in the inflammation, airway inflammation and constriction, specifically in asthma. And these Th2 cells produce specific kinds of cytokines, including interleukins 4, 5, and 13. So what we can look at here is the production of these Th2 cytokines that are specifically relevant to the pathophysiology of asthma. So again, as an indicator of how turned on or ramped up the inflammatory response is in certain people's immune cells. Now, I also mentioned that we're interested in how well inflammatory responses are shut down when they're supposed to. And so we can do this with the same kind of testing, but now with adding cortisol. So as I mentioned earlier, cortisol is a hormone. It's released by the adrenal glands. And when cortisol is present in the bloodstream, it signals immune cells to shut down or dampen their responses, to shut down, for example, the production of those cytokines that I mentioned earlier. But it turns out that some people's immune cells are more insensitive to cortisol signaling than others. So what we can do in this kind of in vitro testing is again, draw blood on you, expose your blood cells to either LPS or PMA-ionomycin, and this time add cortisol to the mix. And what we're looking at here is to see, if we add cortisol, do your immune cells know to shut down the production of cytokines? If they do, we would call you sensitive to cortisol signaling. If they don't, we call you insensitive or resistant to glucocorticoids. Okay, so that's the mini background. So now let me get into kind of what the questions are that we look at related to resilience. And specifically, what we're interested in is trying to understand what some of the psychosocial factors are that might protect low SES, low socioeconomic status youth, from poor physical health outcomes. So first of all, why do we think that health-related resilience even exists? So let me show you an example of this from another study. So this is one of Sheldon Cohen's studies. This is a sort of classic study in the health psychology field. And this study, the original of this study was actually done here in the UK. So Sheldon Cohen has this paradigm where he brings research volunteers into his center, and he deliberately exposes them to a common cold virus. So everybody who participates in his research study gets basically exposed to a common cold virus. And it turns out that when you get exposed to the virus, you don't necessarily come down with the cold. Some people do, some people don't. And so the question he asks is, he brings people in, he exposes them, and then he quarantines them for several days afterwards to make sure you're not exposed to other viruses. So he keeps it very tightly controlled, and he's looking to see who actually gets the cold and who doesn't when he's the one who's exposed them all to the virus. And one of his findings is this one depicted here, which is a classic SES gradient. So this says that adults, depending on the socioeconomic background that you came from as a child, this affects your likelihood of developing a cold when he has exposed you to a virus. So that is those adults who came from lower SES homes as children are significantly more likely to get a cold compared to adults who came from higher SES families as children when he's deliberately exposed everyone to a virus. But within this graph, so that's a classic SES gradient, but within this graph is also the story of resilience, because what we see here in this bar here is that those individuals who are in the highest risk group by virtue of coming from the lowest SES backgrounds as children, despite the fact that 100% of them got exposed to a virus, a cold virus, over 50% of them didn't actually go on to develop a cold. So it's a story, again, of the idea of resilience, that in that highest risk group, you have over 50% of them not getting a cold despite having been experimentally exposed to a cold virus. Why is that? Why does that happen? So that's the kind of question that we're interested in our research group. So in my talk today, I'm going to illustrate a couple of different kinds of psychosocial factors that we've looked at. And to show you the kind of work we've done, I'm just going to illustrate one factor at the individual child level, which is a set of coping strategies that we call shift and persist, and one factor at the family level, which is the role of nurture and parenting, and talk about the ways in which this might help to promote health-related resilience. Okay, so let's start at the individual level. So what we've hypothesized is that there may be a set of coping strategies that are particularly adaptive in a low SES, low socioeconomic status context. And this is a set of strategies that we call shift and persist. And shift and persist has two components. One that's about how people respond to the immediate stressors in their lives, that's the shift part. And the second, which is about their broader outlook in life, and that's the persist part. And the idea here is that for many individuals who come from low income, low SES families, many of the stressors that they face in their lives are largely uncontrollable for them, and they often have very few resources for dealing with those stressors. And under those circumstances, we hypothesize that perhaps the most adaptive way of coping with these sorts of stressors is by essentially accepting the situation for what it is and working to adjust the self to the situation by doing things like changing one's emotional reactions to a situation, changing the way you think about the situation, rather than trying to change the situation itself, and rather than trying to get rid of the stressor, because oftentimes that won't be within one's control. But we also hypothesize that it's not just enough to go through life accepting all stressors that happen and constantly having to shift yourself in response to these stressors, but that it's also important to persist with adversity that happens in one's life by doing things like finding meaning, finding the kind of meaning in the difficulties and the challenges that one faces in one's life, by maintaining optimism, so maintaining the hope that things can still get better in the future, and by finding new ways to get to goals when one's goals become, when sort of obstacles come up that impede one's pursuit of goals. And so what we've hypothesized is that among low SES individuals, those who are able to engage in the combination of both shifting and persisting, not just shifting, not just persisting, but able to do both, are going to show this physical health-related resilience. And that is because in the short term, what that shifting is going to do is reduce physiological responses acutely to individual stressors because they're accepting the stressors and trying to just sort of adjust themselves to the stressors. And that over the longer term, maintaining that positive outlook combined with shifting oneself in response to stress is going to slow down some of these longer term pathogenic processes related to disease, like the inflammatory kind of responses that we talked about earlier. So we've done now sort of probably 4 or 5 different studies on the effects of shift and persist. And I'm going to show you examples from just 2 of the studies that we have. So the first is a sample of healthy adolescents, where we brought in teenagers, a sample of teenagers and a parent. We interviewed the parent about family socioeconomic status, and we administered a shift and persist questionnaire to the adolescents. So the shift and persist questionnaire asks about how they cope with stressful situations. Examples of shifting include things like when stressful situations come up, the extent to which you try and think about the positives that can come from that situation. And examples of persisting is about sort of the extent to which they believe that there's a larger meaning or purpose or reason for their life. Okay. We then drew blood on adolescents, and that allowed us to assess this kind of pro-inflammatory phenotype, both in terms of glucocorticoid sensitivity, so what happens when we incubate your immune cells with both that combination of LPS to stimulate cytokine production, but then we add cortisol and see if your cells know to shut down the production of cytokines. And in terms of low-grade inflammation. So what we can do is draw blood on you and measure how much of these cytokines, these pro-inflammatory cytokines, are circulating in your bloodstream on a sort of at a general level, at any kind of at rest or basally. And that gives us an indicator of low-grade inflammation. So when we look at this, when we look at these analyses, what we find are significant interactions of family socioeconomic status with shift and persist. And they're such that the benefits of shift and persist are only evident among lower SES youth. So we have lower SES youth in the solid line here, higher SES youth are in the dotted line. Shift and persist scores on the x-axis, and on the y-axis is what we call glucocorticoid resistance. So this is how much cytokines you're producing after your immune cells see that combination of LPS and cortisol. So higher numbers are bad here because your cells are not responding to that signal from cortisol to shut down the production of cytokines. So what we see here is that among lower SES youth, as shift and persist scores increase, we see better glucocorticoid sensitivity or less glucocorticoid resistance. So these youth, lower SES youth, who are high in shift and persist scores, when we incubate their immune cells with LPS and cortisol, their immune cells know to shut down the production of cortisol. In contrast, low SES youth who are low in shift and persist, their immune cells are still continuing to produce these cytokines. And in contrast, when we look at higher SES youth, what we find is no benefit of shift and persist. If anything, the effects appear to be going in the opposite direction, where shift and persist appears to be somewhat detrimental. When we look at levels of low-grade inflammation, so these are about the circulating cytokines in your blood, we see a similar interaction of socioeconomic status by shift and persist, and this interaction again suggests that the benefits of shift and persist are evident only amongst lower SES youth, such that as amongst lower SES youth, as shift and persist scores increase, your levels of pro-inflammatory cytokine circulating in your bloodstream decrease. In contrast, amongst higher SES youth, we see, again, no such benefit of shift and persist. If anything, the effects appear to be going in the opposite direction. But now you could argue that with these results, that these are still sort of intermediate biological measures, in vitro stimulation of cytokines, measures of cytokines in peripheral blood. What does this actually mean? Does this actually have any relevance to clinical health outcomes? So we looked at this question then in a sample of children with asthma to ask a similar kind of question about the effects of shift and persist. So here we recruited a sample of children, ages 9 to 18, physician diagnosed with asthma. We again brought children in with a parent, interviewed parents about family socioeconomic status, administered the shift and persist questionnaire to youth, and here drew blood on youth and measured that sort of inflammatory phenotype specifically in the context of asthma. So if you remember, this is about now Th2 cytokine responses to stimulation by PMA ionmycin. And again, because it's a clinical sample, we also have the ability to measure clinical outcomes. So not just markers of inflammation, but also clinical outcomes like the extent to which youth are having to use their rescue inhaler because of exacerbations of asthma, because of asthma symptoms over a 6-month period, and the extent to which they're having to miss school because of their asthma over a 6-month period. So what we find when we look at these analyses is, again, a significant interaction between family SES and shift and persist predicting asthma outcomes. So if we first look at the inflammation outcomes, this significant interaction shows, again, that the benefits of shift and persist are only evident amongst lower SES youth, such that amongst lower SES youth, as shift and persist scores increase, these youth's immune cells are producing fewer cytokines in response to PMA, fewer Th2 cytokines in response to PMA ionmycin, compared to lower SES youth who are low in shift and persist scores. So these youth are showing that kind of more ramped up or turned on inflammatory response where they're showing an exaggerated production of Th2 cytokines in response to an equivalent dose of PMA ionomycin. And again, in higher SES youth, we see no evidence of beneficial effects of shift and persist. And if we divide up the sample to show you the data points of the low and high SES group, what we see is, again, a similar pattern where you see a negative association of shift and persist with asthma inflammation scores only amongst the low SES group, so such that higher shift and persist scores are associated with less production of Th2 cytokines, stimulated production of Th2 cytokines. In high SES youth, you don't see any such benefit of shift and persist. Now, when we look at asthma clinical outcomes, we see again a similar kind of pattern, significant interaction effects of SES by shift and persist. And again here, the benefits of shift and persist are evident only amongst lower SES youth, such that lower SES youth who are high in shift and persist have less asthma impairment over the following 6 months, so they're missing school less often because of their asthma, they're using their rescue inhaler less often because of their asthma. And in fact, low SES youth who are high in shift and persist look more like their higher SES counterparts with asthma than they look like their low SES, like other low SES youth who are low in shift and persist. And again, if we break up the sample to show you the individual data points for low and high SES groups, we see that the negative association between shift and persist and asthma impairment scores is evident only amongst the lower SES youth, such that higher levels of shift and persist are associated with less use of your rescue inhaler, less school days missed because of asthma. And no such association is present amongst higher SES youth. So in sum, what we find with some of the work that we're doing on shift and persist is the idea of context-specific coping strategies that are beneficial. That is the idea that there is a particular constellation of coping strategies that we call shift and persist that's beneficial only to those who come from lower SES environments or circumstances. And it's beneficial to the extent of buffering lower SES youth from detrimental inflammatory profiles as well as from detrimental asthma outcomes. Okay, so now let's talk now about moving more broadly than the individual child to the family level. And let's talk about the role of nurturant parenting. So by nurturant parenting, I'm talking about having a parent who's warm, who shows understanding, who's affectionate, who pays attention to you as a child. And nurturant parenting is probably in the developmental psychopathology literature the most robust factor that has been found to protect youth who grow up under adversity from poor outcomes. So that is that youth who grow up under poverty, but who have nurturant parents, are found to have better psychological adjustments, so fewer mental health problems, fewer symptoms of depression, better social competence, and fewer behavioral problems. But now much of this literature has focused on social, emotional, or academic outcomes, though we do know that from the animal literature, the putatively equivalent of nurturant parenting, that is, in rats, high levels of maternal licking and grooming, has been found to buffer adult rats from elevated physiological responses to stressors. And so we were interested in, is there any evidence in humans that if you grow up with a nurturant mom, that you will have better health outcomes? Some reasons to think that this might be true come from some previous literature, such as a study by Gary Evans, which looked at the effects of maternal responsiveness as a buffer for the effects of poverty on allostatic load, which is a cumulative index of physiological risk that is a predictor of heart disease and stroke. And so what he finds here is his measure of cumulative risk here is a composite measure that includes measures of poverty. So one way to think about this is that what he finds is that the typical association of higher levels of poverty with higher allostatic load, higher physiological risk, is evident only amongst youth who grow up in households where they have a mom who's low in responsiveness. When youth grow up in a household that's high in maternal responsiveness, they don't show that expected association between levels of poverty and allostatic load. But now this isn't a sample of children, of 7th and 8th graders, and we were interested in the question of, is there any evidence that this might persist over time? So if you grow up with a nurturant parent, does this continue to affect your health as you become an adult? So can this affect clinical outcomes in adulthood? So to ask this question, we turn to a sample in the US, a large national sample in the US called MIDAS, Midlife in the US. This is a sample of, it started with a sample of over 7,000 US adults, and then from that sample, they recruited a subsample to do this the biological measure. So the subsample is 1,200, adults ages 25 to 74. And in this, as part of the study, what they did was they assessed childhood SES by asking participants about what their parents' own level of educational attainment were. So as a child growing up, how much education did your parents have? They assessed childhood parental nurturance. So from both the mother and father, how understanding was your mother and your father of you when you were a child? How much attention did they pay to you? How warm were they? And this was asked separately for mothers and for fathers for when they were growing up as a child. And then they had participants come to clinical research centers and participate in an assessment of metabolic syndrome. So metabolic syndrome is a cluster of risk factors that includes abdominal obesity, high blood pressure, impaired glucose control, and lipid dysregulation. And you can diagnose it by being above sort of clinical cutoff levels on certain of these measures across a cluster of these measures. And metabolic syndrome, when it's diagnosed, is considered a precursor to other chronic illnesses such as diabetes and heart disease. So they were able to assess metabolic syndrome in these adults and then look at whether the presence of a warm parent affected their likelihood of having metabolic syndrome as adults, depending on their socioeconomic status that they came from as a child. And what we found when we looked at this sample is we found significant interaction effects of childhood SES by childhood maternal nurturance, predicting metabolic syndrome components. So on the x-axis here, we have childhood socioeconomic status. So this is your parents' level of educational attainment from less than high school to high school degree, some college, bachelor's degree or higher. On the y-axis, we have the number of components of the metabolic syndrome of each of those things, blood pressure, obesity, glucose control, that they were above clinical cutoffs on. And what we find here, this interaction effect, is that if you came from a higher SES family as a child, it didn't matter if you had a warm mom or not. You were at low risk for metabolic syndrome regardless. But if you came from a lower SES household as a child, a less educated household as a child, then levels of maternal nurturance really matter. That is, that if you came from a low SES household as a child, but you recalled your mom as being very nurturing, you had significantly lower levels, fewer components of the metabolic syndrome in which you were clinically elevated compared to if you came from a lower SES household as a child, but you did not have a nurturing mom. And again, if you came from a lower SES household but had a nurturing mom, you were more similar to your higher SES counterparts than you were to low SES adults who didn't have a nurturing mom. Now, I have to also add that I'm sorry to have to say for those of you who are fathers in the room that the interaction effects of SES by nurturance, parental nurturance, emerge only for maternal nurturance, not for paternal nurturance. So paternal nurturance doesn't appear to have the same kinds of protective effects as maternal nurturance does, at least not in this sample. And for those of you actually who were here yesterday and heard the talk, one of the discussants mentioned the idea about the importance of father presence in the household. And I think that these findings are actually not inconsistent with that in the sense that you might imagine that father presence could still be important, but maybe for reasons other than nurturance. And maybe that mothers and fathers are serving different roles in the household on average, and so that there is still importance to father presence, but it's perhaps not for the reasons of nurturance. But in any case, these sets of findings and others from the research literature got us thinking about this question of, so if these findings are actually true, these are all observational studies, obviously, so we can't know for sure about causality, but if these findings are true, is it possible that we could change the way that some families do parenting? And if you could change parenting, could you produce beneficial effects on children's health? And so that led us to the idea about doing intervention studies. And we had the great fortune here of being able to partner with Jean Brody from the University of Georgia. And Jean does parenting interventions in low SES African American families. And so in one particular sample, for example, that he has, it is recruiting children at a pre-adolescent stage, so when they were 11 years old, with their mothers. And he randomly assigned families to either receiving an intervention called SAFE or to being in the control group. And those who were randomly assigned to receiving the intervention, it's called Strong African American Families Intervention. So in this intervention, parents were taught about nurturant, so warm and empathic parenting techniques, but at the same time, how to maintain high levels of control and communication and good communication strategies with their child. Children were taught about the importance of abiding by household rules and as well about strategies for coping with stress. Families participated in a weekly intervention for 7 weeks where a counselor worked with both the parent and the child separately and then brought them together to practice these parenting techniques. Those who were randomly assigned to the control group were mailed 3 general flyers about child development. Now, this intervention was initially designed to try and prevent the development of substance use and behavioral problems in what was considered at-risk, low SES African American youth. And the intervention was efficacious in doing those things, which was great. But what happened was that 8 years after this intervention happened, we had an opportunity to go back to these youth and to draw blood on these youth. And that allowed us to measure these sort of circulating basal levels of pro-inflammatory cytokines, so to get at that idea of chronic or low-grade inflammation. So we could ask the question of, did random assignment to a parenting intervention or not earlier in adolescence change their cytokine profiles at the age of 19? And what we found is that it did. We measured 6 different cytokines. We found significant effects across all 6 cytokines. I'm just showing you 2 here as an example. What we see here is that those youth who received the SAFE parenting intervention had significantly lower levels of pro-inflammatory cytokines compared to youth who had been randomly assigned to the control group. So they're showing lower levels of chronic or low-grade inflammation if they received a parenting intervention compared to the control group. So again, we were very excited about these results because they suggest that you can actually experimentally manipulate or you can change the nature of parenting in families, and in so doing, you can change cytokine profiles in the youth. But now again, these cytokine profiles, you could argue, are an intermediary kind of biological measure. Do we know that it has any kind of clinical significance? Does it really have any meaning? So we thought about, well, is there any way we can look at clinical outcomes? These are all pretty young, young adults. And here, 6 years later, so that was at the age of 19, 6 years later, we had an opportunity to go back to these youth again. Now they were age 25. And here what we could do is measure the presence of metabolic syndrome, because this is one outcome, clinical outcome, that you do tend to find in young adulthood, that you're able to see the presence of emerging in young adulthood. So we measured metabolic syndrome, which, as you might recall, is that cluster of risk factors for heart disease and diabetes that includes abdominal obesity, elevated blood pressure, impaired glucose control. And we also had measured at baseline levels of unsupported parenting before they started the intervention. And what we found here was when we looked at effects on metabolic syndrome, a significant effect of the interaction effect between intervention status and baseline levels of unsupported parenting on metabolic syndrome components. So that is the idea being that what we found was essentially that the intervention was most beneficial in terms of metabolic syndrome outcome to those who started with the highest levels of unsupportive parenting at baseline, or in a sense to those who perhaps needed the intervention the most. So that is, if you look at this graph, on the x-axis here we have levels of unsupportive parenting from low to high. And again, same kind of outcome, the number of metabolic syndrome components in which they're showing clinically elevated levels of. And we have our safe parenting intervention, this is a dotted line, and the solid line is the control group. And this line right here shows you that above 1.2 standard deviation, this is where region of significance testing shows that there's significant differences between the two groups. So meaning that at higher levels of unsupported parenting at baseline, we're seeing significant differences between the intervention group and the control group on metabolic syndrome at the age of 25, such that those who receive the safe parenting intervention are showing elevations of fewer components of the metabolic syndrome compared to those in the control group, amongst those who started out, whose family started out with high levels of unsupportive parenting at baseline before they were given intervention. So again, suggesting effects on clinical outcome, but particularly for the group that's perhaps most in need of parenting intervention efforts. So what we found in terms of at the family level is that nurturant parenting can buffer those who grow up under adversity from both heightened inflammation as well as from heightened metabolic symptoms. Okay, so for the last part of my talk today, I want to actually shift gears and talk about resilience in a different way. So for all of the talk so far, I've talked about this idea of health-related resilience, so meaning having good physical health outcomes despite growing up low in SES or despite growing up under adversity. But when most people talk about the idea of resilience, they often refer to resilience in the academic or the social-emotional domain. So for example, we can take a look at this graph here. This is a graph showing your likelihood of going on to college based on family income. And what we see is a classic SES gradient, not surprisingly. Those students who come from higher income families are significantly more likely to go on to college. And this is of those who finish high school. But what we also see in this graph is, again, a picture of resilience, because what we're seeing in this dark bar is that amongst the highest risk group, those who come from the lowest income families, that of those who finish high school, 50% of them are still going on to college, despite the fact that they come from the most at-risk group being the lowest income group. And so we often talk about these youth as our success stories or as overcoming the odds. And at least in the US, we devote a lot of time and resources to talking about how we can provide resources to disadvantaged youth to allow them to achieve these kinds of successes. There's the sort of narrative in the US of the idea of pulling yourself up by your bootstraps and being able to overcome the adversities that you're born into and achieve kind of a better life. And while it's true that these youth go on to have better life outcomes in the sense of better education, higher paying jobs, better mental health outcomes, we became interested in the question of what do their physical health profiles look like if they show this kind of resilience? And in fact, as we started to think about it, we began to wonder whether there might actually be some costs to this sort of resilience in terms of physical health. And the reason why we thought about this is because if you think about sort of what it takes if you are a youth of color who comes from a family of poverty, what it takes to make it to college and be and sort of succeed in that way is incredibly high levels of self-regulation. And by that I mean incredibly high persistence and hard work, a focus on future planning, kind of keeping your eye on the ball of wanting to make it to college and thinking about your future, and the ability to resist temptations, negative temptations that are all around you in your environment. And you often have to do these things very much on your own because you're doing them without the support, oftentimes of parents who have gone to college themselves, much like many middle class and upper class students have the benefit of, so you don't have those sorts of resources at your disposal. And so what we began to think about is the idea that in order to, that level of self-regulation maintained over years of time, that kind of sustained effort may take a physiological toll. So while it might be good for you academically, it might lead to good life outcomes, perhaps what you have to go through in order to achieve that success might take an internal kind of physiological toll on you. And so we tested this question, we tested this idea. We've done this in, again, 4 or 5 different studies at this point, and I'm going to show you some of them, but not all of them, where we asked this question of might there be cost to exerting high levels of essentially self-control, specifically in low-income kind of minority youth. So in a sample, for example, of African-American adolescents, where we interviewed parents about family socioeconomic status, in this longitudinal study that we had, earlier in adolescence at ages 11 to 13, what we did was we had teachers rate children's levels of self-control. So to get away from having kind of child self-reports, we had teachers make ratings of the extent to which children are good at, that particular child is good at sticking with tasks until they're finished and not being distracted by other children or other things. And then we follow these youth into young adulthood. And at the age of 19, we measured a variety of mental health and physical health outcomes. Mental health outcomes including externalizing behaviors like acting out delinquent behaviors, as well as internalizing behaviors like depression and anxiety. I'm just going to show you the graph from externalizing for today. And as well, allostatic load. So this is what I mentioned earlier. It's a composite multi-system indicator of physiological risk. It includes measures such as obesity, blood pressure, and stress hormones like epinephrine and norepinephrine. And it's a composite indicator that predicts risk for heart disease and mortality in adulthood. And so when we look at these kinds of outcomes, what we find in these analyses are significant interaction effects of family socioeconomic status by self-control, predicting both mental health and physical health, but in opposite directions. So the graph on your left shows mental health outcomes, the graph on your right shows physical health outcomes. So what we see here is that the lower SES group is in the dotted lines. What we see here is that for mental health outcomes, higher levels of self-control are good, as you might expect. So among lower SES youth, those who show high levels of self-control have fewer externalizing problems. They're acting out less. They're showing less delinquent behaviors. We show the same pattern for internalizing behaviors. Higher levels of self-control are associated with less anxiety, less depression. But what we see on the right here is that same high levels of self-control are bad for low SES youth in terms of physical health. So the higher the self-control, in this case, the higher the allostatic load, the higher the blood pressure, obesity, these outcomes. So self-control so it's a phenomenon that we call skin deep resilience, because the idea here is that above the skin, by external indicators, these youth are looking good in that they're succeeding academically, they're showing few mental health problems, but below the skin, they are struggling because they're showing higher levels of, for example, allostatic load. We can look at this question in another way in terms of thinking about, okay, well, what if we think about who actually makes it to college and who doesn't, instead of just self-control? And do we see any kind of evidence of skin deep resilience if we look at who makes it to college and who doesn't based on whether you grew up, your socioeconomic status of what you grew up with? So again, in another sample of African-American youth, what we find is, again, evidence for skin deep resilience in the sense of divergent patterns for mental health outcomes pictured on the left versus physical health outcomes pictured on the right. So here what we have is neighborhood poverty that you grew up in, the percentage of households in your neighborhood that live below poverty levels. So 0% means that you live in a higher income neighborhood, 60% means you live in a low income neighborhood, basically. We have youth in the solid lines who make it to college, youth in the dotted lines who don't end up going to college. What we find here in terms of your likelihood of using substances, marijuana, drugs, smoking, alcohol, basically, is that if you come from a higher SES neighborhood, there's very little substance use, no differences between the groups. If you come from a low SES neighborhood, we see differences between groups, and they're as you might expect. If you're somebody who makes it to college, you're using less substances than if you're someone who doesn't make it to college, if you come from a low-income neighborhood. But at the same time, making it to college, while associated with better substance use profiles, is now here associated with worse physical health profiles. So these youth who come from high poverty neighborhoods, but who make it to college are showing significantly higher levels of allostatic load than their counterparts who are coming from high poverty neighborhoods and don't make it to college. And what you see here is that the benefits of going to college, they're really only evident if you come from a higher income family. So here where you see that making it to college is associated with lower levels of allostatic load compared to not making it to college. But now again, you can argue that with these two studies that I just showed that they're showing again this sort of intermediate biological risk variables like allostatic load. Is there any evidence of skin deep resilience when it comes to clinically relevant health outcomes? So we have another study where we looked at skin deep resilience with respect to metabolic syndrome as an outcome, and this was a larger sample from a study of adolescent health done around the country, around the US. So a sample of 14,000 adolescents that also allowed us to separate whether the effects were specific. The previous studies we had done were specifically in African American samples. This allowed us to say, is this specific to minority or youth of color, or is it general across all youth? So we had a measure of family disadvantage, or essentially family poverty. We have whether they made it to college or not. And then it's a longitudinal study. So from after assessing whether they make it to college, they're followed for a number of years afterwards in terms of mental health outcomes like depressive symptoms as well as metabolic syndrome at ages 24 to 32. And what we find here is that the effects for depressive symptoms for the mental health is as you would expect. If you make it to college, you have fewer depressive symptoms. If you come from a higher income family, you have fewer depressive symptoms. But what we find in terms of metabolic syndrome is that there's significant interaction effects of essentially family SES by college attendance, specifically among youth of color, among Black and Hispanic youth. And no significant interactions in white youth. And this interaction is such that among lower SES adolescents, essentially, making it to college, going to college or higher is associated with a significantly greater likelihood of having metabolic syndrome compared to if you don't go to college, if you come from a lower income family. And that's essentially, again, the benefits of college are only evident if you come from a higher income family, where going to college is associated with a lower likelihood of metabolic syndrome compared to not going to college. This pattern is true in Black and Hispanic youth, but not true. There's no interaction effect in white youth. Okay, so now you might ask, well, does this have relevance also in a clinical sample? So I'm going to show you one last study of skin deep resilience, and then I'm going to end my talk there. So in a clinical sample, so as you know, we do a lot of our research in children with asthma. So we asked, is there any evidence of skin deep resilience in asthma? In children physician diagnosed with asthma, here what we did was another benefit of the study is that in the previous studies we had always inferred that it's that striving in a school context that it creates this divergent pattern for mental and physical health outcomes, but we never probed that directly before. So here we had an opportunity to bring in youth and interview them about their school stress, chronic levels of school stress. So we could see whether it was specifically stress in the school domain that creates this skin deep resilience profile. We had child reports of self-control, so the extent to which they're good at sticking with tasks, persisting, hard work, kind of striving at things. And then we had these measures of asthma that I've talked about earlier. So the idea of how ramped up their inflammatory response is, how much Th2 cytokines they're producing in response to PMA ionomycin, as well as glucocorticoid sensitivity. Are they able to shut down that Th2 cytokine response when we add cortisol to the mix? And because it was a clinical sample, we could also look at outcomes, including over the next following 1 year after we did these interviews, how often was the family having to contact the physician because of their child's asthma. And what we found here were significant interactions of school stress by self-control predicting our asthma outcomes. So what we see here is that the group that's showing the essentially worst outcomes in terms of asthma inflammation is the group that is high in school stress, so experiencing where youth are struggling a lot with school, experiencing a lot of difficulties in school, variability in grades, struggling, needing additional help, but they're sticking with it. They're showing high levels of self-control. They're persisting, striving, maintaining that despite the fact that that there's a lot of stress around school. Those are the youth who are showing the greatest Th2 cytokine production in response to PMAI and myosin, compared to youth who don't show high levels of self-control or youth who aren't experiencing high school stress. We see that when we look at how ramped up the inflammatory response is. We also see that when we look at glucocorticoid sensitivity, that the highest risk group is that group who's experiencing a lot of school stress, but still sticking with it and maintaining high levels of self-control, persistence, and striving. These are the youth whose immune cells, once you add cortisol, are still continuing to produce the highest levels of Th2 cytokines, despite the signal that's telling their immune cells to shut down the inflammatory response. These are also the youth who are showing who have the highest number of physician contacts over the 1-year follow-up period. Those youth who are showing high levels of school stress, but again are exhibiting high levels of self-control and striving, are over the following 1 year showing the greatest number of physician contacts, again compared to those youth who aren't showing a lot of self-control or those youth who aren't showing school stress. But now if we look at mental health outcomes in these youth with asthma, what we see is, again, consistent with the skin deep resilience pattern, the idea of the benefits of self-control for mental health outcomes. So these youth, again, who are showing high levels of school stress but high levels of self-control, in this case, higher levels of self-control are beneficial in terms of anxiety and depression symptoms in a way that they are not for asthma inflammation or for clinical asthma outcomes. So what we've been finding with some of this more recent research on skin deep resilience is this idea that particularly low SES youth of color who exhibit high levels of striving appear to have good mental health outcomes, but are at risk for poor physical health outcomes. So then just to sum up, and then I will end there and leave some time for our discussants. What we've shown in some of our resilience research is the idea that at the individual level, there is a set of coping strategies that we call shift and persist that we believe are adaptive specifically to low SES youth in terms of their inflammatory profiles and asthma outcomes. At the family level, we find that maternal nurturance in particular can buffer low SES youth from heightened inflammation and from metabolic symptoms. And we find the idea of skin deep resilience, that low SES youth who strive hard to succeed often show good outcomes externally in terms of education, outcomes, income, mental health, but appear to have the worst physical health profiles. Thank you.
So thank you very much, Edith, indeed, for that fascinating talk. I'd hope you're going to give us a few more answers, but I think you've set the scene for some very good discussion. So what I should have said at the beginning for anyone who wasn't here last time is that following the main talk, we have two discussants, and then the floor will be opened for general questions. With regard to general questions, the critical point is to wait until you've been given the roving microphone before you speak. This is a method of crowd control that I believe is much used in primary school, but anyway. The first discussant, delighted to welcome Marina Svan Eisendorm, who's a Wellcome Trust visiting professor at Sydney Sussex College here, and also a visiting professor at the Institute of Public Health at the University of Cambridge. His research interests include attachment and emotion regulation across the lifespan and in various cultural and clinical groups, the neurobiology of parenting, the correlates and consequences of child abuse and neglect, and family interventions. And he has, in his research, applied meta-analytic and individual patient data approaches to a range of topics in developmental psychology and psychopathology, and is interested in the sociology and history of attachment theory. Marius, over to you.
Thank you so much. Thank you, Robbie Dusinski, Guy Skinner, Jonathan Mount, for organizing this wonderful symposium. And I'm delighted to be able to make comments on the former speaker and the the discussion that we heard yesterday by Edith Chen and Greg Miller, for several reasons. The first is they are doing groundbreaking research. That's without any question, and it's wonderful to go in depth, listening to them, seeing how overarching the research program is. Second, I'm very impressed by there being a duo. I have experienced duets myself. I think it's a wonderful 1 + 1 is 3 kind of combination that you are exemplifying in your research, in your scientific research. Yesterday I had the privilege to sit near to your son, Jona, and he is a lively exemplar of 1 + 1 is 3 as well. So last reason that I'm delighted to make comments is that it's provoking some thinking about what resilience exactly is. It's a very difficult, complicated concept. It's understudied. There's very few efforts in the world, in the scientific world, in our field. There's one Cambridge lab led by Van Harmelen that's concentrating on this topic. And I would like to shed some light, maybe not, I don't know, that's for the experts to decide, from a perspective, a specific perspective of differentiability theory on this concept of resilience. It's work done together with, thinking together with Marian Bakermans-Kranenburg. And I was put on this trajectory because of your mentioning of the SAF study, the Strong African American Family Intervention. I was well acquainted with this work because it is one of the cornerstones of differentiability theory. What Jean Brodie and Stephen Beach in their fabulous research, very large sample of very difficult to reach African American youth showed was that in fact there's a lot of main effects, and it was the emphasis that we heard in the talk by Edith Chen, lots of main effects, but most importantly, lots of interaction effects. And I think main effects have to be found in the interactions. This is a dictum by Uri Bronfenbrenner, and I think he was right at the spot here. And interactions are, of course, the basis of differential susceptibility. What he showed in one of his papers was this pattern, that in a polygenic manner, if you have more risk genes, you're profiting more from a supportive parenting intervention program. And in this case, it was as outcome variable alcohol abuse or use, but it's being shown by Beach and Brodie in many different outcome areas. So what it means is that risk genes are labeled as risk genes, I think mistaken as risk genes. It should be called susceptibility genes, because these genes are not in a main effect related to the starting point of these families and these children. So it's a randomized controlled trial. They are all the same at the beginning in terms of their alcohol use or their externalizing behavior or internalizing behavior patterns. The difference is going to emerge along the road because the experimental group, and in that experimental group, those who have been carriers or are carriers of the risk genes are profiting most of this change for the better in their environment. And that's exactly what differential susceptibility is trying to prove in all kinds of different ways. That is that some children, and adults as well, and by the way, adolescents and adults as well, are more affected by the environment for worse and for better by the rearing experiences than others. So, and that's totally contrary to the dominant kind of model, which is the double risk model, diathesis stress model. That is that vulnerable and typically developing children develop differently only under the conditions of environmental stress, whereas the differential susceptibility model predicts that they will do differently also under optimal circumstances. So one of the first indicators or empirical evidence was produced by Tom Boyce, and he was a former colleague of Chen and Miller in Vancouver, pediatrician, who looked at immune reactivity to stress. What he did was a week before and after the transition to kindergarten in 4-year-olds to take blood samples and see what their immune reactivity was. And then looking for a longer stretch of time, how two groups, the low and high scoring in terms of this response, immune response, how they developed in terms of, or how they showed respiratory illness incidences. And what they found was that in terms of low immune response, there's in fact no difference between the children who came from backgrounds with a lot of stress versus those who came from backgrounds with very little stress. They only found a difference in those who had high immune responses, the black dots here. And in a certain very specific manner. Not only that there was a combination of two negative components, a high immune stress response, plus a high background with high life events, stressful life events. That's what the double risk model would predict, but it's also on the other side of the equation a totally different reaction, namely that there's less respiratory illnesses in that same group of high immune responders when they are growing up, are functioning in a rather nice environment, came from rather nice homes. So it's going both ways, for better and for worse. And that's why Tom Boyce uses this metaphor of orchids and dandelions. The orchids to represent those who are very susceptible to the environment. Orchids are in the hands of very able gardeners, blossoming, flourishing as no other flower is what he argues, whereas in the hands of a bad gardener, they are withering away quite quickly. And that's different with the dandelions. Dandelions can grow anywhere in the world, in any niche, whether it's harsh climate or not. I'm a little bit of a different opinion. I think this is the most beautiful set of flowers that I can imagine. A field of dandelions, you can't imagine that a field of orchids would make the same impression. Dandelions, by the way, are very particular in terms of their adaptation to niches in all kinds of ways. They are apomictics, so to say, and that means that they are all monozygotic twins in a way. They are clones of each other. They have the same structural DNA, and their adaptation is totally through epigenetics, through methylation patterns. So it's a fantastic flower, in fact. Anyway, we are working with this metaphor. And as you can see here, this is the group of children, adolescents, adults with no risk genes, no risky temperament, no risky stress reactivity, and they function relatively independent of the environment quality, whether poor quality parenting, optimal parenting quality. It doesn't matter so much for their developmental outcomes. And this is a cumulative risk, or that's a stress model. The red line shows that there is no difference between those groups except when there is a negative environment. If there's a negative environment, those with a constitutional risk genes that are risky or a temperament that is difficult, then they are going to be more negatively developing than their peers in the yellow line. That is a stress which is neglecting the other side of the equation, and that's this side, the positive side. These children, adolescents, adults with these risky genes or risky temperament or risky stress reactivity seems to do better in many domains compared to their peers without those risky genes in positive environments, in warm environments, for example, in warm families. Because of our focus, our obsession maybe even as clinicians, as psychiatrists, as psychologists, on this negative side, on negative development, negative characteristics of individuals, we have lost sight of this positive part of the equation, and we should have both in view to be able to see that it's differential susceptibility and not cumulative risk that is the basic of development. Now, what is resilience from this perspective of differential susceptibility? There's a very different, large set of definitions, and a series I have listed here. The Oxford Dictionary says the capacity to recover quickly from difficulties, toughness. So that's an internal kind of characteristics, internal resilience, you might say. Positive adaptation to adversity despite serious threats to adaptation or development. That's Marston's and Marston's definition. Also more internally than externally, maybe. A very beautiful way of operationalizing resilience used by Laura van Harmelen, looking at the difference between in the prediction of early childhood experiences, negative childhood experiences, and later psychopathology, the difference between the children or the youth in terms of their residual scores, meaning that those higher in the residual scores are more adaptive and those lower are less adaptive. So the resilience operationalized in terms of a statistical algorithm, which is, I think, a wonderful opportunity to work in this field in a quantitative manner. Then the last quote is Glenn Roisman's statement, which is focusing at resilience as an external, as a buffering system. And I think those two, focus on internal and focus on external resilience, is, I think, important to take into account. And that's what I think is also possible through the lens of differential susceptibility theory. We see here the two models, and what we see is that if you would like to define resilience in terms of this model, then you have this internal resilience in the low susceptible subgroup of children and adolescents and human beings in general, and you have the high external resilience in the group of those who are susceptible to the environment, who have in this negative environment, for example, low SES, for one person who they feel safe, trustworthy, have a safe kind of basis to explore the environment. So that's the difference between internal and external resilience that might be exemplified in this very short video clip. This is the stimulus that we did show to the respondents. It's a Walt Disney film. It's for all ages, by the way. But 4-year-olds looked at this, and what we see is this example of a child watching these type of video clips. So it's a mammoth eating Brontosaurus. Big, isn't it? The idea was here to study temperamental fearfulness and how that would moderate the effects of this, looking at these frightening video clips on the anxious reactions, the fear reactions of these children, measured by SEL, skin conductance level. So these children were hooked to an SEL assessment instrument. Parent was in the main study was behind the one-way screen. These children looked at these film clips. This is the second one, and you have to guess which one is the most fearful in terms of the temperament. So Make a guess. This the former or the latter one? Most fearful in terms of temperament. That's the right answer, because they are both of a fearful temperament. If you assess it with standard questionnaires, they will all both score for a fearful temperament. They had totally different skin conductance level reactions to this frightening video clips. So if you look at this child, fearful temperament, raised in a low quality home, parenting, insensitive, he is reacting with high stress to this, looking at the video clip. The blue line, low fearful, is not really affected by the background of high quality, low quality. They are all relatively moderate in their reactions to these frightening video clips. And this is a very interesting case. This is a fearful child, an exemplar of a subset of fearful children from a very warm, sensitive background, and they score lowest, statistically significantly lowest on this SEL in reaction to these frightening video clips. So the interpretation will be that these children in the first few years of their life have experienced this type of events or video clips even stressful. They have learned that their parent is available if the stress level is going up to a certain threshold that they can't manage themselves to cope with. So, and then they know the parent will be available if the anxiety is going to raise too high, and that's not the case with a child raised in an insensitive environment. So this is a marker of differential susceptibility, and it's totally changing the reaction to the environment. And in terms of the resilience, what you might call high external resilience, is that what is being shown with a child that's fearful, but depends upon the, you might call it exoskeleton of the buffer of the family on the one hand, and those in the blue line, the low fearful children who have this internalized kind of resilience and endoskeleton, you might say, to use two terms that yesterday I heard from John Davis, 94-year-old pediatrician, beautiful man. So my question is for the discussion, what is resilience? Is it helpful to make the differentiation between an internal resilience kind of term and an external resilience kind of term? I found on the internet thousands and thousands of tips to care for orchids, and that's exactly what the problem is, isn't it, with orchids as most susceptible flowers. Thank you.
Thank you very much, Mariner. So one of the themes of yesterday was how interdisciplinary the study of socioeconomic status and effect on health was, but I hadn't anticipated that botany would come into this. So thank you for expanding the interdisciplinary to even another one. So our second discussant, welcome to Pasco Fearon, who's a professor and chair in developmental psychopathology at University College London. His research focuses on the mechanisms of socio-emotional development and the processes involved in risk for psychopathology. And he is particularly interested in the intersection between social and biological processes in children development.
Thank you very much, Robbie and Jonathan, and it's been a huge privilege for me to meet and to hear from Greg and Edith. So it's been a wonderful couple of days, and I imagine your brains are packed full of information and inspiration. So I'm going to just, reflect a little bit on some of the questions that have come up to me in the last 2 days. As Jonathan said, I mean, I've always been fascinated, I think because I started as a biologist and I changed to become a psychologist late in life. So I've always been interested in this question of the relationship between the social environment and child's development and the underlying biology, and how those three things all relate to each other. Don't have any brilliant answers to these questions, but these are the questions of our time. And as Marinus pointed out so eloquently, Greg and Edith's research program is just a beautiful example of programmatic, hypothesis-driven questions on this topic of the interface between social development and biology in a way that has massive implications for public health. So it's incredibly exciting work. I wanted just, one of the things that I came away pondering about was just how incredibly pervasive the impacts of deprivation and socioeconomic status is, and what a challenge that presents to us in trying to disentangle their effects. So I was listing, there aren't many things that you could look at, actually, if you're interested in child physical and mental health and development, that doesn't have a strong socioeconomic gradient. And we were joking the other day, just yesterday, that people have often not thought about these things, even though, and in fact, we've all done sort of regression analyses where we try to look at, what predicts what. And I think there's been a tendency in the field until relatively recently to not pay too much attention to that enormous beta or R squared, or however you want to do it, that is really about socioeconomic status. And we've actually usually partialed these things out rather than actually studied them in and of themselves. And that's the work that Edith and Greg are doing is a brilliant example of actually how much we can learn by actually studying this thing, because it's potent and it's incredibly important socially. But as I said, it's very challenging because it's clear that if you want to look at the relationship between socioeconomic status and a particular outcome, you have to think very carefully about all the other things that might be impacted. And this is a classic problem in observational longitudinal research, is how do we tease all of these different things apart? We saw some examples yesterday from Greg's talk about how inflammation may be associated with depression, and it was unclear, but there were hints that there was a possibility that depression may perpetuate or amplify inflammation. Inflammation may also confer vulnerability to depression. So these are complicated relationships, and any one study struggles to rule out all of the other possible confounders, and that's sort of one of the things that I'm going to reflect on a little bit. But also just to give you a couple of examples, a little bit more in sort of my area of research, where socioeconomic status shows such powerful effects. So here's the one that you probably all know about, and it's just unbelievable. Actually, I think this is just a socioeconomic status of young infants and their language production, and you can just see what within the first year or the first 2 years of life, the difference between the children of parents who have a college education versus those who don't is absolutely enormous. And by 3 years of age, the numbers of words that young infants can produce is about double the size for people who have a college education versus those who don't. So it's actually a staggering fact. And nursery school teachers and people who think about the impact of language deficiencies for children's future development are very concerned with this problem, and we've not been very successful in tackling these sorts of inequalities. There's an interesting story there that there's clearly quite a bit of evidence that some of these sorts of inequalities related to SES and language are mediated by parental behavior, which I think fits very nicely with what Edith was telling us about in a very different domain. So what I was really struck by is how many of the relationships that we're talking about, whatever the outcome turns out to be, whether it's a biological one or a social one, obey some sort of similar principles and laws, although also some very interesting exceptions that Edith also pointed out, and those exceptions can be sometimes more important than some of the consistencies. But thinking about socioeconomic status and thinking about the mediating processes related to the family environment, and particularly parenting, I think is an extremely important way of trying to understand some of the mechanisms involved in socioeconomic status and children's health and social outcomes. Here's another example. I had a friend recount an anecdote to me where he'd been doing some neuroimaging research, and he spoke to the radiographer, and he said, wait a minute, is that I just had a look at the data, and there's this great big correlation between these structural brain parameters and parental education. Is that right? and the radiographer said something like, "Oh yeah, we always have that. I mean, it's a real pain, so we have to partial all of that out." And he said, "What? Are you serious? There's an enormous effect there, and we weren't aware of it." And since about 2010 or so, people have started to look at brain development in relation to socioeconomic status too, and finding very, very similar patterns. So this is an example of a very nice study from the United States, looking at various parameters of the structure of the brain. This is cortical surface area in various different regions, showing that it also has quite a strong socioeconomic gradient, and it's non-linear. So in this study, the strongest gradient is really at the very lowest end of the socioeconomic spectrum. So my point being that again, just to reinforce the point that socioeconomic status has such pervasive effects on the brain, on language, as well as on health and the biology of information. It's also quite clear that these sorts of effects on brain development start very early in life. So the study I described on the last slide was 10, 11-year-olds. This is a very nice study looking at very young infants, and this is just trajectories of structural brain developmental growth, grey matter volume, in infants whose parents are of different socioeconomic status. And you can see that those trajectories are diverging from each other very early. By somewhere after the first year of life, there are reliable differences in total grey matter volume in young infants. So again, actually it reminds me that Greg made a point yesterday that some of these effects are happening incredibly early, including during a pregnancy itself. So now that's interesting, again, because it shows how pervasive these impacts are. It's also interesting when we try to disentangle some of the temporal patterns, because it's an interesting question. When is it that the brain or the immune system or the language system is amenable to or open to being influenced by socioeconomic disparities? And we can see actually quite a bewildering pattern of points in development where there is plasticity, as it were, to these sorts of effects, and they seem to vary across different systems. So we know that placental function could be impacted. We know that adolescence can be impacted. So how do we figure out how these things are all interconnected? It's actually extremely difficult. And it occurred to me yesterday that is it possible that so much of these sorts of effects that we were looking at yesterday and today could be driven by these early placental differences or fetal development or anything, those sorts of things? That's an important question to try and tease apart. When are those effects being made? Because that's going to tell us quite a lot about what we might want to do by way of intervention. I made this slide again just to even further emphasize how horribly complicated a lot of this seems to be, because I started to think, well, let's think about what do we mean by socioeconomic status, because it's a sort of an envelope that you put things in, but there are so many potential exposures hidden within the label of socioeconomic status. And I've just listed some of those, and I've made a rough distinction between what we might call exposures, so the presence of adversities, but also about deficiency, so the absence of what would be important factors that promote early development that may be absent. And we can think of them all as being overlapping and correlated, and they may impact on our biology in complicated ways. There may be direct effects on, the immune system itself. So, for example, one pathway that occurred to me was that, it may be that children growing up in very impoverished communities, some of the communities that I work with actually, where they will be exposed to high levels of toxins, high levels of infection. They'll be living in much more overcrowded and insanitary conditions, these sorts of things. Those could directly impact on the biology of the immune system. But of course, there are other routes where these sorts of effects could be made too. And we would talk, and Edith was talking very eloquently, very much about psychological mechanisms related to stress. And so the challenge, I think, is to disentangle these different kinds of pathways, because again, they suggest very different modes of intervention. So I think it's fascinating to think about that, and also to think about what kinds of study would you want to do to try and disentangle these sorts of processes. Oh, and yes, and of course all those things are unfolding over time developmentally, which makes it even harder and even more, of course, interesting. Greg picked up on this, and Edith thankfully answered it, because, of course, the key question for so many of us is these are mostly correlational studies, and the question is, if you actually affect a change, does it causally control the outcome? So and of course, clinically, the question we want to know is also, if we make some of these changes, does it actually improve immune function? And even more importantly than that, if you improve immune function, does it impact on health outcomes? And it was fantastic to see a brilliant example of that from the Strong African American Family Project, which probably, is it the only? It's one of the very few clinical trials where immune function has been an outcome, but there are some very nice clinical trials that have looked at other related outcomes like allostatic load and cortisol response and so on. So there's an accumulating body of evidence that psychosocial intervention can causally control and have a positive impact on these sorts of biological measures. And that's really exciting. And also from an intravenous or trial design point of view, we start to think about, well, let's design trials that are trying to affect those biological processes, because as psychologists, those tend to only come to mind rather late in the day. And what we don't have yet are these are mostly secondary measurements of trials that had a different purpose. And I think the next generation of trials, there will be psychosocial interventions that are trying to impact directly on these sorts of immune or stress responses, and that will be really, really exciting. As I said, it's fabulous to see how this sort of intervention can impact on immune function, and it resolves a really important causal question and shows that you can do something, which is very nice for both my sides of my personality, the sort of technician who likes to think about causal processes and the clinician who likes to think we need to do something to help. So it's a really, really exciting study. It also led me back to this question about when do these effects sort of stick? Because it's, I think it's plausible that there are kind of developmental programming processes that go on that might begin very early, which of course might make you be concerned that at later psychosocial intervention would have no impact. But that's clearly not the case. So even if there are early developmental programming effects, that's clearly superimposed on what I imagine are contemporaneous psychosocial adversities that are driving these kinds of immune responses. And in fact, the resilience question also suggests that, because what we're seeing is these sorts of moderating effects happening, quite late in development, in adolescence, in the college school years too. So again, it's showing us, yes, maybe there are some early origins, but these sorts of processes are also happening live. And this is a very common phenomenon in a lot of areas of developmental psychology, that a lot of the causal action, even if you can see the roots of it in early development, are being maintained by contemporaneous ongoing stressors, and that's also good news in terms of the potential for intervention. The lovely findings about shift and persist and nurturing parenting, this is where I think many of my colleagues would see a lot of similarities to the work that we do. We would tend to talk about effortful control, and in fact Edith did talk about that. And again, it's interesting how these kinds of protective processes are coming out in different domains of psychological and biological development, and we have quite a lot of evidence that nurturing care is not only a positive effect, it has a positive effect on children's outcomes, but also buffers against stressors, and we've seen quite a lot of studies that suggest that. Wanted to say one more thing, which is that Edith had separated out nurturing parenting and SAP, as we're calling it, and shift and persist. But I would also raise the likelihood, actually, that these two things are linked to each other. So rather than being entirely separate buffers, many of our studies have shown, and from other groups, that nurturing parenting promotes effortful control. So these two things, although we can think of them as partially independent, and they may become more independent as a child leaves the home and goes to college and so forth, but these are causally related. And we have quite good evidence from longitudinal data that parenting, supportive, responsive parenting, promotes forwards in time the child's future effortful control. And we know that that also appears to impact positively on the child's later functioning. So it would be fascinating to do similar kinds of longitudinal studies to test these sorts of mediational questions where we're looking at biological outcomes like immunity, and perhaps some of that work's been done actually, and that would be, I would be delighted to see that. I wanted to end on a final note. Somebody asked yesterday whether any of this work is being done in far-flung parts of the world where rates of poverty are sort of, you know, on another level to what we're used to. And so that the answer is yes. I mean, it's not us only, but obviously it's much more fun for me to plug my own work than somebody else's. So I take this opportunity just to flag up a study that we just completed not so long ago, which was in the townships outside Cape Town, where we asked a lot of very similar questions, not with immunity, but about stress physiology. But of course, doing this in a context where children are exposed to horrendous levels of poverty and community violence and so on. But what's very interesting is that the pattern was very similar to what Edith presented in her slide. So, you know, poverty clearly having an impact on the stress system, but also being buffered by the quality of sensitive and responsive care. So we've got a long way to go, but I suspect that these sorts of phenomena are actually quite universal in many parts of the world. So thank you very much for your wonderful work. I'll stop there.
Thank you very much, Pascal. And I was particularly struck with my sort of background in epidemiology and public health of the very obvious point you made, but is one that's escaped people for decades, that socioeconomic status isn't something to sort of adjust out of the explanations, but it could be a fundamental explanation to understand a very important point. If Maris, is he? Oh, there you are. Sorry, yeah. Want to join us? So we've come to the questions from the floor part. So if anyone would like to ask a question, please make a gesture to receive the microphone.
Oh, thank you. Anne-Louise Kinmont. I was Professor of General Practice here, and I feel very privileged actually to be part of that. This was a really fantastic discussion. Thank you all very much, and thanks, Robbie, for involving in this. Several of you have referred to the SAFE trial as being, oh, thank goodness, randomization. That's what we like, the magic of randomization, which deals with the confounder that you cannot measure or hadn't thought of. But it does raise a couple of questions, and I think given how important this trial is to the argument, would it be possible to talk a little more about the validity? Because we went straight into the results in two regards as to how the randomization worked. There was quite a long follow-up, and then in the fidelity of the intervention as to whether actually the intervention group were differentially exposed to the intervention. The reason I ask this particularly is because I have done many trials, and I even sometimes get positive effects. But when I look to see whether the hypothesized mechanism that we had, the theoretical framework for the trial, drives through to the interpretation, we always find the effect was obtained by some other means and not by a hypothesized mechanism. So, thank you.
I can start this off, and then if either of you want to add anything. So, yeah, those are both very good questions. So, in terms of the randomization, it was just a pure, sort of 50-50, half the group randomized to, sort of to get the intervention, the other half not, and the control group never receiving intervention. So that difference was preserved throughout all of the. Well, they were mailed the three flyers about child development. So they received a mail. Right. Yes. Yeah. So right. So both groups are going through their lives and their development, right, as they would normally once the intervention ends. That's absolutely true. So you can't, right, and you can't control what's happening in that regard. But they're not receiving any sort of active intervention anymore. In terms of the fidelity question, so. Gene Brody and his group, there are a number of papers that he's published that actually shows that when he looks at kind of mediators of the intervention effects, that the strongest mediator that emerges is actually changes in supportive parenting, which is obviously the big target of the intervention study. So there are, so for example, the finding that I showed about the changes in cytokines by intervention, there's a secondary analysis that looks for mediators of that effect, of the direct intervention effects on cytokines, and shows that the changes operate through, the effects of the intervention operate through changes in supportive parenting. And he has a number of other papers that have shown that as well. So I think in that particular case with that intervention, it actually does seem to be operating through the changes in parenting as one of the primary mechanisms.
Maybe to add some comments, I think you're pointing at the problem of mortality, of differential mortality in the control and experimental group. I think there's a huge mortality, a huge going out of the study of many children, and intent to treat, I don't think that's often used in our kind of research, so that makes certainly for biases in all kinds of directions, and we don't know what direction. Yeah, and I think so we cannot be sure that the baseline similarity between the two groups, intervention and control group, remains a similarity across several years. And that's why I think why Pascal Viron mentioned the need for replication. It's so important to have replication and replication and again and replication. And I think it's indeed a problem to find a priori, to hypothesize mediating factors and to find really them back in your experimental research and results. One of the maybe few exceptions, maybe I'm home refereeing here, but is maybe the link between sensitivity and attachment security. What we found meta-analytically across many studies, that the more the effect on parental sensitivity is, the higher the effect is on infant security of attachment. And that seems to point into the direction across many studies of a causal relation between sensitivity, very crucial kind of causal mechanism to attachment security. Still, the in-between linkages on the neurobiological level have to be found, because one of the things that we found in the study that was referred to yesterday by Marian Bakerman-Skranenberg about the way in which sensitivity is influencing brain architecture, structural brain components, we wanted to see this as a mediating factor to later externalizing behavior problems, because there is this link between sensitivity and externalizing. You would predict that there is some kind of intervening brain structure potentially, but that's not true in this specific study, and I think it's very difficult to find this pin in the haystack of really a mediating on the level of there's a big gap between brain and behavior. And that's, I think, the case in many intervention studies as well, that try to go for neurobiological level of specificity of intervention effects.
I really enjoyed your clearly seasoned experience of doing trials, because I absolutely agree with you. I mean, they're messy processes doing trials. So I would say that, replication absolutely. But I think convergence is the other really important word for me, because it's about conversion lines of evidence, which is not just, it's about the plausibility of the whole picture. So all of the studies that Edith presented were already pointing in that direction, that this should work, and then a trial shows that it does, well conducted, and if it's replicated, it becomes a convincing story, I think. The other thing that I've written about a little bit recently, which is exactly what you're saying, is that the more that we measure mediators, actually the more that can persuade us that actually what we think is changing, and it becomes a better and more stringent test of the hypothesis. The other thing that we don't ever do, I think, is measure things that we think are not mediators, but could be alternative, counterfactual mechanisms. Nobody does that. We all think of the things that we'd like to be true. We never think of the things that could be making things worse than we should be controlling for. So I'd like to see mediators, but also counterfactual, the mechanisms that could also be mediators of the treatment effect that are unexpected, and that's a very kind of unusual step to take currently.
Thanks. I was interested in how you came up with the shift and persist, because you didn't say where that came from, really, if that was just a good idea you had around the coffee table, as it were. And why do you think that is almost seems to be detrimental to the people that are in high socioeconomic status? Because they seem generally kind of good things.
Good things. Yeah, sure. Thank you for that question. So in terms of how we came up with it, I think that the origins of it was really in trying to think about, I would say very much along the lines of differential susceptibility, the idea of context-specific adaptive coping strategies, and sort of to try and, I think, move the field of psychology away from the idea that there are good traits and bad traits and we want more of the good and fewer of the bad, to thinking about really if we can understand the context in which people live, that may give us some clues as to what is adaptive, and sort of really trying to think about the idea that there may be that maybe when we think about positive psychological traits, we're missing the boat a little bit if we're not considering that kind of context. And so as we sort of thought about that, and we drew on kind of some of the literature about what happens under uncontrollable stressors and things like that, we kind of got over time to the idea of shift to persist. Now, as to your question about why it's not beneficial for the in higher SES groups, I think that part of our argument there is that for higher SES individuals, there are maybe different kinds of coping strategies that may actually be more adaptive. So if you think about kind of more proactive coping strategies aimed at kind of eliminating or diffusing a stressful situation, that if you're somebody who's higher in SES and you have more resources to kind of throw at a problem, it might be more beneficial in terms of stress responses to eliminate the stressor rather than to try and change oneself and adapt oneself to the stressor. So it's the idea that although those are in general, they seem like kind of good strategies, they may be most adaptive in kind of a certain context in which there isn't much that can be done and there are few resources. And there is actually a study that's just coming out from Rich Slatcher's group, which is on a sample of low SES youth from rural China, that shows that if you compare the sort of proactive coping to the shift and persist, that proactive coping appears to be detrimental. Proactive coping is detrimental to cortisol slopes in a way that shift and persist is not. So the idea that there are sort of multiple different types of coping strategies, and certain ones are adaptive in some contexts and other ones are adaptive in other contexts. That's sort of
David McDade from the London School of Economics. I'm fascinated by the two lectures yesterday and today. I come to this as a health economist, not getting lost sometimes with the cytokines and all the inflammatory stuff. But I wanted to ask from a policy point of view, particularly from today's talk, if I'm a policymaker and I have a limited budget and I'm thinking about early years interventions or interventions with expectant mothers, etc., should I be thinking more about a targeted approach based on the kind of talks the talks, which suggest that there's more benefit if you target towards those of low socioeconomic status, or is it a question of a balance, more the kind of a Michael Marmot proportionate universalism approach, where you provide for everyone but you target more of those in most need? I'm just curious, how can policymakers at this stage react and reflect on what you're saying?
Yeah, that's a great question. I think that's one we struggle a lot with, and we're still trying to kind of figure out what I think the sort of best message might be. And I think that it's, I'm in some ways often of two minds about the sort of targeted versus more universal approach. I think that the benefit of the kind of targeted approach is the idea, as you're kind of alluding to, of sort of most efficiently utilizing resources and saying, okay, if we know who's at greater risk, if we know that among a kind of lower SES group, if we could promote certain strategies or we could do certain kinds of interventions, or we saw from the kind of parenting intervention that it's most effective for those who start off in families that have harsh sort of harsh family environments. So if we can assess that in the beginning and we can say, oh, here's a more vulnerable subgroup, wouldn't it make more sense in some ways to mobilize more resources towards the more kind of vulnerable subgroup and devote the sort of precious few resources we have towards that subgroup? So I think there's a lot to be said for that argument. I think that sort of one difficulty that can arise with that sort of argument is that in some ways a more universal kind of approach is perhaps less stigmatizing and less, the sort of targeted approach in some ways can sometimes rely on people to self-identify as a member of that vulnerable group in order to receive those resources that you're trying to offer. But if they don't perceive themselves in that group or they don't want to identify in that group, then by creating a more universal approach, you have sort of a broad, kind of set of strategies that you think, sort of might just sort of reach out more generally. Now, there are also issues about, if you think about the differential susceptibility model that Marinus was talking about, that what might be good for some might actually be harmful for others. So then maybe the universal approach is not, might not be advisable in all conditions. So I think it's a very complex question that I think there's not an easy answer to.
Maybe we did a large national prevalence study of maltreatment in Holland, and it was mirrored in the national incidence studies in the United States. It's policy directed. It's trying to, in every 5 years, to have a prevalence figure for maltreatment, very different types. What we found was a figure, 120,000 children being abused, maltreated, neglected. Now, if you go for the most deprived group of parents without a partner, jobless, lowest SES, the most at-risk group in all kinds of statistical ways, you find in the group 10,000 children. So if you would do a targeted intervention, you would reach 10,000 children, to make it a very crude comparison, and you would not reach the 110,000 in higher socioeconomic strata or in better circumstances. So from that perspective, I think it's a risk to go for targeted. And besides the whole issue of self-fulfilling prophecies, if you are put into a box, you identify with that box and stay there. I think this is one of the more powerful arguments to have universal interventions. Certainly in this stage of level of universal support for parents, which is still very low in our country, and I think in the UK it's not totally different.
I completely agree with both of what you said. I think the only problem that I'm thinking really as a clinician now that we were talking about an extremely financially constrained system. So I think rationally we're more or less forced to do an awful lot of targeted intervention in this country, certainly. And then the question of stigmatization becomes really important when we work with some of the most socially excluded communities. What it means to be receiving a parenting intervention, for example, is very problematic. I think that's why there is quite a move towards, at least there's some interest and political push to move the sorts of interventions and services that we're talking about into settings that themselves are less stigmatizing. So putting them in the community, putting them in schools, and embedding in a subtle way different levels of stepped care. Because I think actually you can talk to a teacher who's thoughtful and been trained in mental health, and they can do their own, but based on their relationship with the child and with the family, judgment about the need for this child to be somewhat escalated without it becoming, you're receiving some sort of welfare payment that makes you stand out as being differently in need. And so I think there's some nice sort of compromises that can be thought about where this all works more fluidly based on long-standing respectful relationships in the community.
A temporary lull. Could I ask a question? So I'm kind of struggling a bit with the biological mechanisms, and I was quite struck yesterday by the data from the US, and I was thinking about the difference between kind of relative and absolute poverty. So as I said, the US, the wealthiest country in the world, and high socioeconomic gradients with health outcomes within all the different groups and so on. But I don't, maybe it's just my lack of imagination in terms of causal mechanism, but it would seem to me that if you reached a certain level of wealth, education, it shouldn't matter that you haven't got as much wealth and education as someone who's a bit wealthy. So I was quite struck by your comment on the 9th and 10th deciles of those, if you're very, very wealthy, you're still not quite as well off as in terms of health as someone who's very, very, very wealthy. And I just couldn't, I struggled with that and thinking, how's that going to be explained in terms of inflammation and so on. I don't know if you've got sort of any just comments in how relative and absolute poverty, socioeconomic status and mechanisms tie together.
Sure. It's, I think that's a great question. So the work that we presented is mostly focused around absolute levels, as you were pointing out, and where we look at actual, sort of actual income. But there is a large literature about that idea about relative deprivation or sort of relative perceptions of standing and how that might predict physical health. So, for example, there's a large literature on subjective perceptions of social status and where you stand, and its links to physical health outcomes over and above objective indicators. There's also, there's good evidence to suggest that that kind of relative ranking matters and matters sometimes above and beyond the kind of absolute level. So there was a debate actually here in the UK that went on between John Lynch and Michael Marmot about this idea of the absolute versus the relative. And one of the analogies that's made about the reason why relative standing might be important even if you have a lot in an absolute sense is that people can't help but compare themselves to others, and that in making those comparisons and seeing that your standing is less than somebody else's, that creates a certain amount of stress and desire for kind of achieving and kind of rising in the social rank, even if you have an amount that is at an absolute level sufficient. And so I think it was Michael Marmot made this kind of comparison about how, when you fly on the airlines, you have to walk through the first class, seats, and you see all the people who get the better treatment on that, and it just makes you feel unhappy about where you're at, even though you have enough money to fly on an airplane and you can get somewhere that many other people can't. And so it's that sort of sense that human beings have about that sort of feeling the need to have to compare themselves, and then not necessarily being happy with what they have, so that that relative sense of deprivation can contribute to sort of perceptions that then can have physiological effects.
Just a thought. This as you were speaking, it was making me think about something. Apart from that, it would be just such a fun experiment to randomly put first class at the measure their immune function. But I was thinking a little bit about the work that we did in South Africa, and what I find very interesting there is the absolute levels of poverty are just are completely different to what we would experience in the UK, but the rates of responsive and supportive care are minimally different to a UK population, in the population that we worked with. And actually within South Africa, it's the poorest part of South Africa, apart from very rural communities. But so I find that very interesting, because there are some things that seem to be relatively vary quite dramatically between different contexts, and others that seem to be very much driven by kind of local mechanisms. And so these relationships between parenting and outcome, they seem to sort of rescale themselves, so to speak, to local conditions, which I think again reinforces what you're saying. But it also could solve to me a little puzzle, which is that children, I don't think, do have those, or at least not in early development, have that that capacity to think, oh, I wish I had a mum who was as cute as the mum, down the road. That's not how it works. So from the child's point of view, I think it probably is a relatively absolute experience. Maltreatment, I think, would be an example of that. I suspect that a lot of the relativity is coming through the sort of parental experience of referencing themselves with respect to others, but the experience of the child becomes relatively absolute in terms of the parental care.
I was just wondering, in terms of things like shift and persist and the self-control or effort-foot control, what kind of mechanisms you see or you think kind of underlie these? Are these, I guess in terms of the nature-nurture kind of debate, are these things that you inherit from your parents? Are they things you learn from your parents or from other role models? Or is it some kind of gene-environment interaction? What do you see kind of, giving rise to these characteristics?
Yeah. So that's a great question as well, and I think that in part it gets to some of the comments that Marianus was making about the difference between internal versus external sorts of resilience. And I think that for us, when we think about shift and persist, we think of it, it is fundamentally an internal kind of characteristic of a child. But when you think about where it comes from, we have in our kind of theoretical model about shift and persist the idea of how the broader context shapes it, that we're not necessarily hypothesizing that children are born either as high or low shift and persisters, but that the broader social context that they're in kind of shapes the development of shift and persist. And this is something that Pascal also alluded to, the idea that I presented them as separate, but perhaps there's some interconnections between them. So we have, for example, one study in which we've shown, sort of recognizing the idea that for a lot of these low-income youth, there's a lot of instability in their family environments. Part of kind of our thinking about the broader social context is about the idea that youth may be able to develop a kind of shift and persist mindset if they have a role model out there in their, kind of a mentor or role model out there in their environment who provides sort of a stable and positive influence, and that it maybe doesn't have to be necessarily the presence of a mother or father, but that there can be kind of a, sort of some kind of external kind of positive social relationship that then kind of shows children essentially that the world can be kind of a safe place where you can, sort of trust others, and that, you can depend on others, and you can, sort of see the positive in, sort of what might come. So we have some work that's shown that the presence of a supportive role model can essentially facilitate shift and persist in youth that then kind of relates to some of the inflammation and other markers. So kind of a model going from the broader social environment to that sort of shaping shift and persist in an individual child to then affecting inflammatory outcomes.
Well, it's 7:33, so I think it's probably time to draw these proceedings to a close. But first of all, I'd like to thank all our speakers again this evening for some really excellent and thought-provoking presentations. Absolutely marvellous. Thank you. And as I did yesterday, I'd like to thank Robbie and Guy once again for organising such an excellent presentation, set of presentations over these 2 days. And thanks very much for inviting me along. And thanks very much for a great audience. You've asked some very searching and interesting, stimulating questions. So I've certainly got a lot out of these 2 days, and I hope everyone else has too. So thank you to you.